You can have anything. So your job is going to be to figure out what in the world can I handle and what do I need to punt on. So that's the direction I think we need to take this. So take a look. Here's what we got to talk about. I need to make sure that you're prepared to take care of the most common neuro conditions that walk in a primary care office. You know what that is? Headaches. You need to know all about them. I need to make sure you know about Bell's palsy. We had a significant change in a practice guideline in 2012 that has resulted in almost 100% of people achieving complete recovery with Bell's palsy. I want to make sure you know what that is. You should be using it in your practice. You got to know about vertigo. Vertigo is darn common, and the majority of patients who have it you can keep, but there's a small percentage of people with vertigo that you need to get out of your office, and you need to do it pretty quickly. I got to make sure that you know about the most common tremor, rest tremor that we see, and that's Parkinson's disease. I think you will see a question or two or three on your exam about it because we see loads of it in older patients. Michael J. Fox is not the typical patient who has Parkinson's. I need to make sure that you know about tremors. Tremors are very common, and when patients come in, you need to know who can I keep and who do I need to get out. I made a topic or a category called miscellaneous neuro diseases because people keep telling me, Amelie, this was on the exam, this was on the exam, this was on the exam. But you know what? You see this very occasionally in primary care, and I just want you to have a heads up. You don't need to make a diagnosis on these unusual diseases. You need to recognize them as outside my scope of practice and get them referred. And then finally, we're going to end our discussion this morning on dementia, all right, and mild cognitive impairment and what to do with those patients. So that's where we're headed. Hang with me. The number one neurologic disease in primary care, I guess other than pain, is certainly headaches. And everybody in this room has had a headache before. But I'm pretty willing to bet that the headache you have had has been a primary headache. In other words, it wasn't secondary to something else going on, secondary to a tumor, secondary to a bleed, secondary to increased intracranial pressure. Unfortunately, when an elderly patient presents with a new onset headache, it almost always is secondary. Secondary meaning something else is going on and this patient is going to buy one of those expensive tests. But I have to tell you something. You remember this morning when we talked about pneumonia and I told you at age 65 we start to use the E word, elderly? Well, I have some really bad news for you. Because in the realm of neuro, elderly is 40 or maybe 50. So if you're like mid-30s, I hate to tell you this, but neuro is going to call you elderly in a very short amount of time. So elderly patients who present with a new onset headache always buy expensive tests. So let me ask you something. How do you approach a patient who's got a headache? You know, if you work in ICU or you work in the ER, I know what you are going to tell me. You're going to tell me, oh, I'm going to get a CT scan, no contrast, in case it's a bleed. Well, let me tell you, you are getting ready to take a primary care exam. You better take off your specialty hat and put on your primary care hat. In primary care, you cannot order a CT scan for every headache that walks in the door. I'll tell you some more about that in a minute. But let me show you a good way to approach a patient who presents to primary care with a headache. The first thing you do is what you always do. You must get a good history in that patient. And typically the patient is able to give you the history. If they can't, they're not your patient anymore, right? You need to send them out. The majority of patients who present with a headache in primary care are going to have a normal history. They don't tell you something that makes you say, oh, that's an abnormal headache. I know what you've got. Let me send you out. It's typically a very normal history. Here, though, are some red flags. Look at them. Somebody who's got a first or worst headache. In the ER, you know what that means. It's the worst headache I've ever had. This is the first headache I've ever had like this one, and it's a 10 out of 10. When they tell you that in history, they're not your patient anymore. They're going to see somebody else. So with regard to history, these represent red flags. After you do your history, you're going to do a good exam on the patient. And here's what I would tell you. The majority of headache patients have a normal neuro exam. But I want to make sure you get something. And here's what I need to make sure you get. Pain in the head might not be in the head. It may be referred in from somewhere else, and a common place is in the neck. But let me give you an example of something that happened to a patient of mine just a few months ago. This woman is a nurse. Friday afternoon, she began to have this headache. It got worse. She took Advil, didn't get better. Finally, by Saturday night, she said, something's going on. Top of my head feels like it's going to blow off. I'm going to the ER. She goes to the ER. What do? CT, negative. They said, here's something for pain. Go see your PCP on Monday. She arrives in my office on Monday. I'm looking at her, and just the way she described things made me think, something ain't right. This is what she said. Amelie, the top of my head feels like it's going to blow off. She said, it hurts, it burns, I'm miserable. She had a normal neuro exam and a normal CT. The very first thing I did was check her scalp. You know what she had? Shingles. Yeah, so listen, when you hear enough complaints about headaches, you realize that one's unusual, this is the run of the mill, or this is the norm. Listen for those key words that people give you. Do you know how mad that lady was that she paid for a CT scan? And nobody checked her scalp? So what I would tell you is, I'm not a genius, and I'm no whiz kid NP. I'm a regular girl just like you are. But when people tell me things that don't sound normal, put on your thinking cap and expand your differential. So, anyway, don't forget that things that are in the head, that produce pain in the head, are not always neuro in etiology. Look at the red flags. Oh, Lordy, look at age. Greater than 40, right? That's certainly a red flag on exam. What do you think of with neck stiffness, especially with fever? You think of meningitis. And then I want you to look at this word right here called papilledema. Papilledema always seems to appear in your exam. And what do you need to know about it? Well, it represents swelling of the optic disc. It almost always is secondary to increased intracranial pressure, which means we usually see it bilaterally. But here's what I know. I know that you probably didn't see what you said you saw when you used this thing right here. And I know you didn't, because I didn't either. But look, I was just like you, and I had to get out of that darn assessment class, right? So here we go. I'm in the middle of my checkoff, and here's my instructor out of the corner of my eye with a thing, and she's checking off every point I get. And I reach over and I get the ophthalmoscope off the wall, and I do like this, red reflex elicited, and on the corner of my eye I see. All right, good, I got that one. And then I'm going in and I'm talking about a cup to disc ratio, and I'm just telling tales all over. So listen, you will never see what it looks like in the book if you do 8 or 10 of them in a lab. You got to do a lot of them, and I'll tell you, it probably takes about 150 or 200 fundoscopic exams before you really see what you said you saw, all right? But listen, don't feel bad about it, because don't for 1 minute think that you are the only provider that has trouble doing fundoscopic exams. Everybody does, which is why things like this got developed. Or for people who are really bad, they have this. Do you know that this is the way they go now? So somebody comes in and they hit your switch, hit a little button, and then it takes a picture of the fundus, and then you look at your picture and you say, oh, why, that's a normal fundus, or a normal whatever. This is abnormal. So there are ophthalmologists who sit in offices and never see patients. All they do is look at retinal scans and scans that come in from all over the United States and, heck, all over the world. So what I would tell you is, don't feel bad because you can't do this, but practice, practice. I'm telling you, if I can get it, you can too. All right? So just keep practicing. At some point, though, you're going to reach a place where you realize, I have got to get an expensive test on this patient. So how are you going to get this expensive test? You will chase your tail unless you write the right words in your notes. You type the right words in your notes. You will never get that little authorization to get the exam. This will give you authorization for those expensive tests. I want you to look at the words, because your notes need to include one or more of these, and obviously it has to be true. All right? So this is what you put in there, and when the reviewer sees this in your notes, that's when you get your authorization number. So I would encourage you to learn these things, because it helps you get what you need. Now, look at this. 90% of the headaches that walk in your office will fall in one of these three areas, which is why you need to know about these three types of headaches. About half of the headaches that walk in are migraines. That's because those darn things are disabling. When people get them, they need help and they get it. So anyway, let's talk about these tension headaches and finally a little bit about cluster headaches. I made a chart for you simply because I think it will really help you. My background was critical care. So, I thought every headache needed a craniotomy. That was just my perspective. I never thought somebody could have a headache that was kind of benign. Headaches were always terrible for my patients. So when I had a patient and I moved to primary care and somebody came in with a headache, I wanted to CT them all. Well, you can't CT all your patients. I wish that someone had told me this, because I would have slept a whole lot better in my first few years of practice. Let me make sure you know what to look for and document, and you will sleep well. When a patient comes in with a headache in primary care, the first question you ask them is, where in your head does it hurt? And I know that seems elementary, but you have no idea how much that will help you. If someone comes in with a unilateral headache, and I've had it right here and it always is right here, I'm not thinking that's a tension headache. I'm also not thinking that's a cluster headache. This is way more likely migraine. The second thing you document of the 5 critical ones are the characteristics of the headache. Migraine headaches, as you know, are crescendo headaches. What does that mean? It starts at a 1 or a 2 and then it escalates to an 8 or a 10. When they tell you that, I'm thinking migraine headaches. That's not how a tension headache or a cluster headache patient presents. The most important of these 5 things for me is what my patient looks like. If I go into an exam room and the patient is lying on the exam table with the light out, that's a far different headache than somebody who's got a light on reading their iPad waiting for me to come in. So patient appearance should be huge to you. It's simple, but use that as one of your big clues. Look at the 4th of the 5 things you need to get. This, to me, is one of the most important things I ask a patient about. How long have you had this headache? The classic migraine without medication intervention lasts between 4 and 72 hours. If the patient tells me, Amelie, I've had this bad headache, it's been 8 or 10 days now. It's not terrible, but I just can't make it go away. I'm not thinking good thoughts about you. I'm thinking very bad things, and I'm trying to figure out how to get one of those expensive tests paid for in you. So the duration of a headache is a huge clue. And then finally, what else is going on with this headache? Oh, you're photophobic. Oh, you're phonophobic. Oh, you're having nausea. When you look at this, after you've documented these 5 important things, when you have a patient with a unilateral headache that's a crescendo headache, they want a cool, quiet, dark room, it's been going on for 10 hours, and they have nausea and photophobia, I feel very comfortable making a diagnosis of migraine, and I don't feel compelled to get an expensive test in them. You got it? When do you get an expensive test? It is when the headache doesn't fit these criteria. That has got to drive you to get one of these expensive tests. So do these 5 things, document them, and after you look at what you've documented, I think you'll feel a whole lot better about making a diagnosis and knowing to get a CT or knowing not to. So I made another chart for you, and I think you ought to be familiar with these. These are simply symptoms that may be associated with what type of headache. I would tell you right now, and I'll tell you a little bit more about it, but with older patients, you better be on the lookout for temporal arteritis. In fact, I think you'll see it on the exam. I think you'll see it in your exam room. But let's talk about migraines, because half of the headaches that come into your primary care office are going to be these, and you need to know about them. Here's my first question for you. What changes occur in the cerebral arteries during a migraine headache? Like pathologically, or what's going on? Pathophysiology-wise, what goes on with the cerebral arteries? They do what? They dilate. They dilate. So listen, A clue for you is the mechanism of action of triptans. How do those drugs work? They cause what? Constriction of the cerebral arteries. Do the triptans just stay in the cerebral arteries? No. You can get bleed over into the coronary arteries. You can get bleed over into any arteries. So I have a question for you. Obviously, the answer to this question is what? Dilation, right? What happens to the cerebral arteries during a migraine headache? They dilate. So here's what I want you to know. Now that you know the mechanism of action of the triptan is cerebral artery constriction, I want you to put on your thinking cap. And I want to ask you about what diseases you would never want to put a triptan in. What disease might a patient have in whom a triptan is totally off limits? What about uncontrolled hypertension? What about angina? Those are two of the ones that come to mind right away. Those are what we call drug-disease interactions. You got it? Those are examples of drug-disease interactions. It's an interaction between a triptan and hypertension. All right? So it's an example of a drug-disease interaction. You remember I told you this morning about watching TV commercials? We have several commercials on TV for migraine meds. You know what they all say? They all say, be sure to tell your prescriber if you take any medications for depression. You got it? So that's a drug-drug interaction you need to make sure you know about. So anyway, the SSRIs and the triptans are not great drugs to have on board at the same time. That's what you should answer about used to treat depression. So I want you to be careful when a patient comes in and says they have a migraine. I want you to ask them how you know. Because when people have a bad headache, they will say, oh, I have a migraine. Ask them how do they know. If they say, oh, well, I was diagnosed 12 years ago by this certain neurologist, but he's not in practice anymore, you probably know that's their diagnosis. But the criteria that we use to diagnose migraines are not ones you need to have in your brain, but you ought to at least have them in your pocket or your peripheral brain. What's your peripheral brain? Your smartphone, right? Exactly. So that's your peripheral brain. So listen, the criteria that we use to diagnose migraine with and without aura come to us from the International Headache Society. Like, that's the gurus of migraine diagnosis. And again, you don't need to memorize these, but you do need to have them available because these are the criteria that you must document in your notes to arrive at a conclusion of a migraine with or without aura. So don't memorize them, but be familiar with them. You should also be very familiar with the common migraine triggers. And I would tell you, bright light is certainly one of them. What about menses? Absolutely. So again, look at these, because if you can help your patient figure out what their trigger is and they can avoid it, then they can avoid some migraines that they might otherwise get. And let me tell you, that will be a big deal for a patient. What are you going to do once they come in with a migraine? Well, the drug class of choice, unless it is contraindicated, might be a triptan. Triptans do great things for loads of people who have migraine headaches. But anyway, know who you can give them to and who you better not put a triptan in. Well, these are the triptans. It might be a suffix that you put on your drug list or your suffix list. I would tell you that right now I think there are about 4 that are available over the counter. They're all expensive, even not over the counter, excuse me. They are generic. They're not over the counter. They're generic, which doesn't mean that they're cheap. All right? They're not inexpensive. So keep that in mind about this drug class. It may help them, but again, it usually are expensive. And here's something else to consider about the triptans. They work. And you don't want to overuse them because they stop working. So your tolerance for triptan use in a month is about 2 a month. Once people exceed 2 triptan uses a month, you have got to start thinking about this word right here, prophylaxis. Prophylaxis means, little lady with the migraine headache, you can take this every day or twice a day, and it's not going to keep you from having a migraine. Don't make them think they'll never get another migraine. Tell them this drug is going to decrease how many you get. And when you get one, it won't be quite as bad. That's the thought that you need to put in your patient's brains. If they never get another migraine, good. But that's very, very unlikely. So what drugs might be used for prophylaxis? The exam just loves to ask you about a beta blocker used for migraine prophylaxis. They work in some patients, but honestly, we don't have a drug that universally is a good migraine prophylactic med. We just don't, which is why there's several of them available. And I would tell you, you should be familiar with the term off-label. What does that mean? It means it might really work. It might be the best thing since sliced bread. But the FDA didn't say it was okay to use that drug in that patient for that condition. And if you use it and something happens, you'll get a personalized invitation to state board's next meeting. All right? So you don't want to be on the state board of nursing's radar, right? You know that. You never do. Consequently, a good rule of thumb to learn is don't prescribe medication off-label, and if you do, you just need to know that you got a lot at risk. All right? So I'll leave it at that one. Here's your patient. She's a 35-year-old female with migraine headaches who asks for advice about contraception. Like, Amelie, you think it's okay to have this estrogen progesterone? Because look, I don't need a baby. I'm 35 years old. I need some help. But she's got migraine headaches. What should you tell her? Well, if she's interested in asking questions about contraception and she's got migraine headaches, you need to tell her that putting her on an estrogen progesterone contraception at this age does increase her risk of a stroke. All right? Let me give you the details. Here it is. Migraine plus oral contraception does at least a little bit increase the relative risk of ischemic stroke. With that said, if she's got migraine with aura, it doesn't matter how old she is, the risk of a stroke from an oral contraceptive may be way too much. All right? So that's something for you to consider. Generally, in women who are less than 35 years of age, generally the benefits outweigh the risks, provided it's not a migraine with aura. And then finally, women who are older than 35 probably need some other form of contraception besides an estrogen progestin thing because of the risk of a stroke, you know. So anyway, there's a lot to talk to your patient about, and there's a lot to document to make sure that you've had this conversation. What about health promotion regarding migraine? Listen, that's when you really need to begin to think prophylaxis. You got it? More than 2 a month. All right? Everybody with me? All right, let's keep going. What about stroke? Tomorrow morning, we're going to talk about getting blood pressure where it needs to be, lipids where they need to be, and prevention of or diminishment of those cardiovascular risk factors. But sometimes on the exam and always in practice, you wonder about prognosis when a patient of yours has a stroke. This just kind of gives you some ideas about what's a good prognostic indicator for a poor result from a stroke and what may be better. All of these, honestly, ought to be pretty self-explanatory to you. But if you were to see a patient or a question on the exam that gave you an older patient, older than 65, with a infarct location, and they gave you complications that the patient had, you should look at that patient and realize they don't usually have good outcomes. So have an idea what predicts stroke prognosis based on these findings. So let me shift from there, and talk about trigeminal neuralgia. Trigeminal neuralgia is not one of those things that walks in your office every day or every week, but when it walks in, you need to know what to do with it. It's a very common cause of facial pain, and I want you to look at how it's described. It's sudden, severe, unilateral facial pain, and it comes from the trigeminal nerve. When you look at the trigeminal nerve, tri means 3. The trigeminal nerve has 3 branches or divisions. Look at the picture and you can see where those branches are. And you can also look at the picture and see where they can create pain. Now, I want you to look at this and consider. When a patient presents to your clinic with trigeminal neuralgia, they are not just blowing smoke. These people have very severe, impressive, and remarkable pain. This is not one of those diagnoses that someone walks in with and, oh, yeah, I've been having this pain for a couple of weeks. When they walk in with this, they'll tell you, this started yesterday or this morning. I can't take this. Look at how the pain is described. It's intense. It's sharp. It's piercing. It's stabbing. Did you get that attention? You got it? They're going to get your attention when they tell you about it. When you examine them, there are no other neurodeficits that are there, but it's paroxysmal. What does that word mean? It comes and it goes. And when it comes, they will cower because it's just so painful. So what are you going to do with this? Excuse me. One thing you'll realize is that this is way more common in elderly patients, typically older than 40, usually older than 50, sometimes in the 60s. So this tends to affect somebody, usually not a young adult. There is a drug that can work miracles in some of these patients. And sometimes they ask about it on your exam. The name of the drug is carbamazepine. What's the brand name? Tegretol. I don't know if you've had the occasion to give Tegretol to patients, or maybe you've taken it, but Tegretol is a medication that makes people, here's my word, loopy. Loopy in Amelie's definition is a cross between sleepy and drunk. So I don't know if you know your patients do this, but they do. When they have something they want to get rid of quickly, they take their first dose in the pharmacy. Your instructions to this patient better be, listen, Ms. Boudreau, this drug is going to help you, the pain in your face, but don't take this until you get home. If she takes it in the pharmacy, you don't want her driving a vehicle, all right? So you just don't want it. So make sure that you give her those patient instructions with carbamazepine. So let me ask you something. Once she begins to get this med, how long before she feels better? 2 hours? Almost never. 12 hours, she might feel better. 24, she usually says, I think I'm better. By 48 to 72 hours, usually she'll tell you, I am better. All right? So anyway, I think you'll see that. But look for it. All right. I want you to look at this picture. Help me with the diagnosis. The chief complaint in this patient is tenderness at this vascular prominence. What are you thinking? Temporal arteritis, right? So temporal, meaning in the temporal area, arteritis, an inflammation of the artery. Another term is giant cell arteritis. And the most important risk factor that we see in these patients is aging. So look at the age of the people we see this in. Not a 30-year-old. The mean age is 72 years old, so you should have an idea right now about the age of these people who come in with this as a diagnosis. Let me give you the clues. The big clue is that these people have jaw claudication. In other words, as they open and close, they'll tell you, and I've had patients tell me, I think I have that thing my daughter has. What is that, Ms. Boudreau? She has that TMJ thing. Well, an older patient doesn't have TMJ. That's not the top of my differential. When they come in with jaw claudication, they come in with pain, especially over the temporal artery. This has got to be what is part of your differential. So look, sometimes it's accompanied by fever and fatigue, especially when it's accompanied by systemic issues. But to be honest with you, they have headache and jaw claudication in an older patient. When that presents unilaterally, temporal arteritis has got to rise to the top of your differential list. What's your job? Refer, right? You're going to refer. Let's talk about Bell's palsy. Bell's palsy is a problem with cranial nerve 7, the facial nerve. And when a patient presents with this, I would tell you that you need to be on it. You need to be on your game. I did not realize that with Bell's palsy, most people don't have complete recovery. And this is a problem or disease that results in facial asymmetry. The new practice guideline that is out pushes almost 100% of people to complete recovery, which means you got to know this. So take a look. This is caused by a herpes virus, almost certainly. The symptoms are pretty darn classic. You'll see drooping of eyelid, sometimes facial paralysis, and often a drooping of the lip Either all three or one of them. But I'll tell you, the most important thing when a patient walks in with this is to rule out what? Stroke. Once you rule out this is not a stroke, this looks like Bell's palsy, your attention has got to be directed to the patient's eye on the affected side. And here's why. The eye on the affected side will end up with permanent change in vision unless you keep that eye lubricated. So the first thing you ask this patient to do is to close the eye. You've got to make sure that the lid completely covers the eye when they blink or when they close their eye. If the lid doesn't completely cover the eye, and it might not, then you've got a list of interventions you need to put in place right away. Here's what you got to do. You need to make sure that they have an ocular lubricant, meaning re-wetting drops, that they use every hour while they're awake. If the lid doesn't cover the eye when they attempt to close the eye, at nighttime, what you've got to do is get them some gelatinous or like Lacrolube, a gel that they'll put in the lower lid, and then they disperse it over the entire eye to moisten it while they sleep, and then they manually move the eyelid closed, and it gets closed and taped shut for the night. If you don't do that, and they're not able to completely cover the eye will end up with a permanent change in its distant vision and near vision as well. And you don't want to be responsible for that. So that is always your primary concern when these patients come in. Then certainly evaluate the rest of this as I've got indicated for you. And so, function returns for most people, look at the length of time, 3 to 4 months. So you have to have a heads up and tell the patient, excuse me, this is not one of those things that's going to go away in a couple of weeks. This can take months before it completely resolves. And so part of your big job is eye care and psych support and somali. Like, what's the big deal about this? How do I push 100% of my patients to complete recovery? It is with high-dose steroids, and I guess I just gave you the answer to this next question. Take a look. What medication class is the mainstay of therapy for patients who have temporal arteritis, hint about how that gets treated, or Bell's palsy? It is number 2. It is steroids, and here's your recipe. When a patient walks in with Bell's palsy, the steroid doses that pushed almost 100% to complete recovery were this. Days 1 through 5, 60 milligrams of prednisone a day. 60? That's not a Medrol dose pack, right? 60 milligrams of prednisone. Please divide it. 30 in the morning, 30 sometime in the late afternoon or evening. Otherwise, you'll have people bouncing off the walls. They'll clean their house from top to bottom. So the first 5 days, 60 milligrams a day. On day 6, they get 50 milligrams. On day 7, they get 40 milligrams. On day 8, they get 30. On day 9, they get 20. On day 10, they get 10 milligrams of prednisone. So it's not a Medrol dose pack that resulted in a complete recovery. It is very high-dose steroids. So do what you can to get these patients to get started on that, because to end up with permanent facial asymmetry because you didn't know to do this, that's a shame. All right? So anyway, best answer to this, steroids. Everybody have what you need to do to push to complete recovery with Bell's palsy. You got it? All right, let's keep going. What about vertigo? I am pretty sure that everybody in this room has had vertigo before, whether it was self-induced or otherwise, but you probably had vertigo. It is important to remember that vertigo isn't a disease. What is it? It's a symptom, and your job is to figure out why is everything spinning or swirling or turning. When a patient presents to your office with vertigo, your brain needs to flip to the vertigo algorithm. Meaning, is this patient's vertigo central, which means they're not your patient anymore, it involves the brain, get them out? Or is it, the most common thing, a peripheral etiology, which means you are probably going to keep that patient? So is it central or is it peripheral? Some clues that will help you figure out which one it is, since you're not going to be getting an expensive test right now, are these. The severity of the vertigo has nothing to do with whether it's central or peripheral, but these two clues do. The first one, someone who's got vertigo and is unable to walk, they're not your patient anymore. They have impaired gait and mobility, not because they're so dizzy they're going to run into the wall, but they are unable to walk. They're not your patient. They need to go to an ER or get them into neuro right away. That's one big clue. The other clue is this one, and you do it in your office and it's easy. What you want to make sure of is that their vertigo resolves when they look at a distant spot on the wall and they remain very still. If their vertigo continues even though they're doing that, then I'm worried about them. Because benign paroxysmal vertigo, which is the one you will keep, the one that is far more common, resolves at least temporarily if they remain very still and they focus on one object. If vertigo persists 1 minute, 2 minutes, and they're doing that, they're not your patient anymore. It's very likely it's a central etiology. They need some expensive imaging and probably somebody besides you. So those two are big clues for you. Now, peripheral vertigo is the most common. By and far, it is the most common. And the one that we see almost 95% of the time is BPPV, benign positional paroxysmal vertigo. But there's some other examples as well. When I mentioned that sometimes vertigo might be of central etiology, meaning of the brain, these are the ones that walk in every once in a while, but you can't miss them. These are people often who have had some insult to the brain from a close head injury, maybe secondary to MS. They've got something else going on, and you need to get them out of the door as quickly as you can. So here's what you will take care of. It is the most common form of vertigo, and you'll see it in the literature either as BPV or BPPV. This is how these patients present. It's brief and it's recurrent. Typically it is because of something going on in the semicircular canals. I usually tell them it's rocks. I have rocks in my head? Well, kind of. But they've got tiny, tiny little grains of something that's usually calcium in deposition, and it just can't get to the bottom of the canal. If that gets hung up somewhere, you're not going to know what's up and what's down. So that's a common cause of this. And what is classic is that the patient wakes up in the morning and they tell you, Amelie, when I went to bed I felt fine, but I rolled over in bed this morning. Oh! When I rolled over in bed, the world began to spin. That's a common one. What you should be able to do with BPV always is reproduce the symptoms. So on your exam or in your practice, if you see Dix-Hallpike maneuver, that's always what they want you to do. I'm not the smartest bear in the forest, but I'm not the dumbest one either. Let me tell you what happened to me as a new NP. You know, as a new NP, you never know what's behind the door. And you always want to know, what do they have? So I walk in, I knock on the door, I go in. I've probably been in practice maybe a month. And the patient sitting there is kind of holding on to the exam table and he's being real still. And I very quickly determined that he's got vertigo. And I'm so glad I finally know what somebody's got. So I look at him and he's telling me, when I rolled over in bed this morning, the world began to spin. I thought the bed was going to throw me out. So his wife is brought in there. So I'm thinking, Dix-Hallpike, I know that's what I'm supposed to do. So I tell him, Mr. Boudreau, I want to do a test on you to make sure this is BPV. So I look at him and say, Mr. Boudreau, I'm going to lie you down. So just like this picture, I cradle his head and I begin to move him down like this. And he said, oh, I'm getting nauseous. Oh, Mr. Boudreau, I'm almost finished. I lie him down like this. Oh, I'm about to vomit. I'm almost done, Mr. Boudreau. I take his head and I have nothing better to do than turn it right toward me. All over me. So what I would tell you is, I've never done that one again. And I would never do that one again. Here's how I approach a patient with vertigo. Ms. Boudreau, you having vertigo? Oh, yeah, sure. All right, Ms. Boudreau, I want you to lie down on the exam table. I'm backing away. If lying down on the exam table doesn't reproduce her symptoms, then I'm going to say, Ms. Boudreau, look toward the door. Ms. Boudreau, look toward the wall. If I can't reproduce her symptoms, she's not my patient anymore. Because what is classic of BPV is that you are able to reproduce symptoms by a change in position. All right? So I have never done Dix Hallpike again, and I have no interest in ever doing it again. The reason these patients have symptoms is secondary to disturbances in the vestibular system, especially those semicircular canals. And so here's your patient. Your patient is a 44-year-old who presents with suspected BPPV. What symptom is she probably having? And I just gave it to you. Nausea. When the world spins, they get nauseated. Number one, they do not have headaches. How do we help them? Well, you know what they don't know? They don't know that the drug you can give them a prescription for is available over the counter, right? Things like meclizine or dimenhydrinate. Obviously, benzos are not available over the counter. But I'll tell you what, for vertigo, where patients got to travel another 30 minutes or 60 minutes, not while they drive, somebody else is driving, but a melted benzo under the tongue in 10 minutes stops the world from moving. Now, you remember I just told you about using a drug off-label? Don't do it. So if I've got to prescribe a benzo to get somebody somewhere, you can bet my notes are going to read something like, patient very anxious about next episode of vertigo. I'm going to be covered. I don't want to be on State Board's list, right? All right, so bottom line, if it's peripheral, you can probably keep it. If it's central, you got to get them punted in to see somebody else. Everybody with me? All right, well, let's talk about tremors. You know, when a patient comes in with a tremor, your brain has to flip to the tremor algorithm. Is this a rest tremor or an action tremor? What is the most famous of our rest tremors? Parkinson's disease, exactly. And so obviously an action tremor occurs in the course of moving that body part. What do we know about Parkinson's disease? We know it's chronic, we know it's progressive, we know it's a neurodegenerative disorder, and it's characterized by these famous things. A rest tremor. So you always look for a rest tremor to help you differentiate this. As I told you earlier, Michael J. Fox is not the average patient with Parkinson's. He obviously had a very early presentation. Look at the average age, 70. So we see this in older patients. And the cardinal features, of course, of that pill-rolling tremor, right? Bradykinesia, which means a slow onset of movement, and certainly rigidity, which is what takes away a lot of independence from our patients. Here's a Parkinson's man. You see his body habitus. And when you look at that, you realize right away, this man is waiting to fall down, which is what we know about many of our Parkinson's patients. So loads of accidents simply from falling and things like that. But take a look at this question because you need to know about it. It involves the pathophys of Parkinson's. What neurotransmitter is the underlying problem in these patients? It is dopamine, absolutely. Number 2. Which means that all of your medications that are used to treat patients who have Parkinson's symptoms or Parkinson's disease, all are directed toward making more dopamine available. So if you were to see a question on the exam, or you got a patient and you're waiting to get them into neuro, I'm not suggesting that you treat them ahead of time, but I'll tell you right now, the first line drug for most of these patients is going to be a drug like Sinemet, levodopa. You got it? So it inhibits the breakdown of dopamine. It makes more dopamine hang around. They usually get some improvement in symptoms, and generally this is a first choice for patients who are diagnosed with Parkinson's or who have suspected Parkinson's. Because if their symptoms improve on this medication, then the disease or the diagnosis usually follows pretty quickly. Because think about it, we don't have a blood test that diagnoses Parkinson's, and we don't have an imaging study. Patients are given a medication. If their symptoms improve, then generally we think this is what they've got. So again, treatment, you got to watch these medications. You have to watch them because the patients who get them typically are going to have loads of side effects from these medications, especially your older patients. So just be alert to the side effects that all of these meds have. And again, I am not talking about Parkinson's for you to treat these patients. Patients with Parkinson's disease need treatment in a specialty clinic, movement disorder clinic, a Parkinson's clinic, general neuro, wherever you're going to send them. But again, you see them in primary care, and your job is to get them referred. Excuse me. let's look at this next question. So a 30-year-old DNP student complains of tremors and anxiety anytime she has to stand before a group to make a presentation. She is worried about making her capstone presentation. What type of tremor is this? It's a tremor that every single person in this room has had before. It's called a physiologic tremor. You've had it. If this didn't make you nervous or make you shake, you probably got a physiologic tremor if you drank too much caffeine. If you had some event that happened that really made you very upset, you exhibited a physiologic tremor, and that is exactly what this is. Another type of tremor is called essential tremor. It's very common. We see it as people age. It's way more common in families. And you have seen and heard this tremor before. It is way more common in the upper extremities. Okay, people begin to shake. It is a bilateral tremor, not unilateral as we might see with Parkinson's. You've heard this tremor before. Haven't you heard a little old lady who tells you about something that's going on with her? And you hear that little shakiness in her voice? That's a vocal cord tremor. That's an example of an essential tremor, and honestly, it's very common. If I had a patient who exhibited symptoms of essential tremor in the lower extremities, I'd want to get them into neuro because it's very unusual. It could be an essential tremor, which we use the term benign with, but to be honest with you, I would want someone else to look at them. When you do an exam, typically no other neuro deficits. If this is, and you're convinced that this is what your patient's got, what can you try in primary care to help the tremor? A beta blocker works very well. Something like propranolol, a non-cardioselective beta blocker, right? Like a propranolol, not metoprolol, all right? So I would consider that, and that ought to help with symptoms. If it doesn't, I'm sending them to see somebody. In the realm of miscellaneous neuro disorders, this is one I think you need to have a heads up about. Your exam, both exams right now, are all about autoimmune disorders. And I don't know if you know how very, very common they are, but this is certainly one of them you should have a heads up about. MS, common inflammatory demyelinating disease in the central nervous system, way more common in females, especially of childbearing age, right? At least that is when the majority of these patients are diagnosed. How do they present? Well, I would just tell you that the symptoms that they have are bizarre. They're bizarre. They just don't match. What do you mean you lost vision in one eye? Really? Let me see. Yeah, she sure did. She's got weakness or pain in an upper and a lower extremity. Like that kind of doesn't match. Typically, this ought to put you on alert that something is going on with these patients. Sensory symptoms that resemble these. But again, two clinically distinct episodes. They need to go see neuro. Your job in primary care is to have a heads up. This doesn't seem right to me. What about myasthenia gravis? We think that this is definitely an autoimmune disorder as well. And what can differentiate myasthenia gravis from some of these other things that produce weakness is that this one involves what part of you? That's very unusual. The eyelid, right? It involves the eyelid. So eyelid weakness, especially in conjunction with limb weakness, you must think about myasthenia gravis. And I would tell you that's an automatic neuro referral. What about ALS? Lou Gehrig's disease. If you're a big football fan, I think you know what you need to know for the exam about this. You know, the NFL right now has huge things about concussion protocol. One of the outcomes, maybe, of repeated concussions is a disease like ALS from repeated head injury. And one of the things that we see is that this is way more common in men than in women. It may be very associated with football, and so that might make you scratch your head and say, Amelie, Lou Gehrig was a baseball player. How did he end up with this? Well, when Lou Gehrig was in his 20s and his 30s, he played football. He was a running back. But he couldn't feed his family on the amount of money he got for playing pro league football. He switched to baseball because he was a fabulous athlete, and that's when he began to have symptoms. So it wasn't from baseball that he ended up with this. If it was attributable to a sport that he played, it almost certainly was from football. So again, you'll see a lot about ALS coming out because we're seeing loads of this in people who had repetitive head trauma. And again, look at the symptoms that people have. Asymmetric limb weakness, just bizarre. They have something. You don't need to make the diagnosis, but you need to get them out. We're almost there, so hang with me. This is something that, man, it's just really hard to talk about and think about. And that's MCI. It is mild cognitive impairment. So look at what mild cognitive impairment really is. We think that it is a state that occurs prior to the onset of dementia. It's got variable duration, but people begin to exhibit symptoms and changes in their cognitive function. And so take a look. Age is the primary predictor, meaning we see this way more commonly in older patients. Sometimes neuropsychiatric symptoms accompany mild cognitive impairment, but we almost never treat this with medications. It's kind of watched and we see where patients go. Of all the things that you could possibly do that would improve your situation, there is data through a Cochrane review that says that exercise may provide improvement in patients with mild cognitive impairment. So another good plus to be exercising. If all of this leads up to dementia, then this is what you need to know about. So dementia, as you know, is an impairment in memory plus one of the other cognitive domains. That's what dementia really is. Unfortunately, we don't have a blood test that diagnoses dementia or Alzheimer's. We really don't even have an imaging study, although we get them all the time, because here's the deal. 1 of every 5 patients who exhibits dementia symptoms, you ready? 1 of every 5 patients who exhibits dementia symptoms has a reversible cause. You know what that means? You need to go looking for the reversible cause. How embarrassed would you be if someone had a B12 deficiency and you thought they had Alzheimer's? Like, I would close my office. I would. So I am telling you, once you know that 20% of people who present like this have some reversible cause, it changes the way you approach them. Now listen. You're going to interact with these patients because that's the only way we have to discern whether they've got dementia or maybe delirium or maybe they've got a primary psychiatric illness that has emerged late in life. So when you interact with this patient, that is exactly what you're trying to do. You have got to get a good history from the patient, and this is when you just hope that there's a family member who's in the exam room with you who can tell you the right answers to the questions you just asked. Sometimes a little old man and a little old lady come in, and you look at them and you wonder, who in the world drove here, right? Because like, oh my goodness, between the two of them, you know, one can't see and the other one can't hear, so oh Lordy. So my point is, you've got to have some family member who can give you the right answers to the questions you've just asked in history. If you get asked a question on the exam about cognitive testing, or what you already do in primary care in your office, is the mini mental status exam. You should be familiar with it. It is what we use in primary care to assess dementia. It's got high sensitivity and specificity for dementia. And to be honest with you, because it takes about 7 minutes to administer, it is very helpful for all of us in primary care. You've got to do a good head-to-toe physical exam, looking for things that I've indicated up here. Are there any neurodeficits and anything about this patient that makes me think that they are that 1 in 5 who has some reversible cause? And then you need to do what I call Amelie's brown bag test. The brown bag test is, let me see what medicines you're on. Because older patients especially are very susceptible to the anticholinergic effects of medications. How embarrassed would you be if you had an older adult on a TC, a tricyclic antidepressant, and they were having anticholinergic effects, and that's why they couldn't remember what canister the coffee was in? You get it? So you got to do a good brown bag test to make sure that it's not secondary to a medication that someone has put them on. And so, you've heard me say Alzheimer's disease and dementia. Really what I'm talking about is dementia syndromes. That is a more appropriate term because it encompasses a number of different types of dementia. Even though Alzheimer's gets all the publicity, there are many other types of dementia that people walk in with. And so somehow, you've got to find a way to get one of those expensive tests paid for. The American Academy of Neurology wants you to get an imaging study on this patient. Maybe this patient's got hydrocephaly. Maybe this patient has a tumor that's sitting somewhere. Maybe there's something else going on with this patient that represents, maybe they had a stroke. So you've got to find a way to get this test paid for, keeping in mind that 1 in 5 people typically has something that is reversible. How are you going to start your workup? You got to get some labs. You got to get a B12 level. My goodness, how embarrassed would you be if that was the underlying etiology? So get your labs, get an imaging study, and then I would remind you, especially if you have experience with these patients, they can be very, very difficult to take care of. Generally, it's very difficult on a family, and to be honest, you're going to need help and you're going to need to get some resources for your patient and their family. And this, with regard to safety assessments, has got to be at the top of your list. You know, one of the most difficult conversations that you have to have with a patient is about when it's time to stop driving. It's a huge safety issue, and you must make sure that you've got that documented in your notes and that whoever came with them, that you've told them about not driving as well as the patient. So their financial capacity, can they still write checks? Can they manage their bills every month? These are all things that honestly you've got to address, and living alone is certainly one of them. What about the drugs that we use to help people who have dementia? The cholinesterase inhibitors like Aricept and Exelon and Razodine, those typically are the mainstay of treatment. Typically we get patients started on those and see how they do. And there's some other medications as well, but to be honest with you, we don't have a perfect drug for dementia. And we don't have a way, really, to reverse the dementia that these patients exhibit. Which brings us to this. It will help you with a number of those very difficult decisions with the patient, and it is called a CDR, a clinical dementia rating. And if you take care of these older patients, you already know. The CDR looks for impairment in these 6 things: in memory, orientation, judgment and problem solving, in their ability to manage themselves in the community and at home, and finally, themselves personally. They're rated, and that's how you figure out where they can be. You got it? So can they continue to live alone if somebody calls them on a regular basis? Do they need to go into an assisted living? Do they need complete care? When you look and you evaluate patients according to this, you'll have a very good idea and something that is objective that you can put in your chart to help you figure out where the best disposition for this patient is. Everybody got it? What a downer before lunch, right? Listen, take a big deep breath. Let's see where you are, and then we'll get you out for lunch. I want to know which cranial nerves, I don't believe you need to know that. Well, kind of, maybe, a little bit. Which cranial nerves are responsible for eye movement? Not vision, that's cranial nerve 2. But movement. Cranial nerve 3, 4, and 6. How about number 2? Everybody got it? Number 2. A 36-year-old female has migraine headaches. Which medication could be used as a prophylactic agent? Well, we didn't talk about DHEA, but that's for abortion of a headache, right? It's an abortive. Sumatriptan is an abortive agent, and so might butalbital be, though not really indicated for migraines. Amitriptyline, right? That's your prophylactic agent, number 3. Off-label? Mm-hmm. Does it work? Mm-hmm. All right. What's the most common presenting symptom of pseudotumor? What do these women have? Women of childbearing age. They have a primary complaint. What is it? It is headache. Yeah, they've got it. So I have that for you in that chart I gave you. So if you didn't pick this one up, go review that chart. Look at this one. A 35-year-old female who is otherwise healthy has been diagnosed with BPV. She's taken 4 doses of meclizine in the past 24 hours, which is an appropriate dose. What's a common side effect of meclizine? It makes them sleepy, so what do you tell them? Please don't drive. If vertigo's not enough to make you don't drive, please don't drive because you've got this drug on board. And I think this is our last question. A 16-year-old female who is otherwise healthy, 16 years old, was at school this morning when she states that she saw zigzagging lines in both eyes that lasted about 30 minutes. It made her nauseated. She now complains of headache over her right eyebrow. Her neuroexam is normal. What are you thinking? Migraine with aura, right? How about number 2? And we're there.